So before I discuss the topic, I would like to discuss the skeletal framework that we'll be discussing our topic under. So basically, we'll be discussing the topics under these headings. So let's start with definition. So basically, what is hypertension? I feel before discussing any pathological condition, we should always know normal physiology. So what is hypertension? Blood pressure readings for more than 2 occasions. Basically, the occasion should be 4 to 6 hours apart, and that elevated BP reading should be more than 140/90 according to JNC8 guidelines, and the person should be calm, and he or she should not have smoked 15 minutes prior to BP measurement, because the smoking causes nicotine. Cigarette contains nicotine, and nicotine can cause catecholamine release, which can increase the BP. So it is very important that person should not smoke 15 minutes prior to blood pressure measurement, and the person should be calm. Otherwise, there is entity we have called as white coat hypertension, and we will be discussing about it in further slides. So yes, what is blood pressure? Yes, I want this point is to be highlighted that blood pressure is a pressure exerted on the vessel wall by the lateral column of blood. So when we talk about blood pressure, we always say that it exists in as a systolic blood pressure and diastolic blood pressure. So why there is systolic blood pressure and diastolic blood pressure? So if we see the logic, whenever the heart contracts, there is blood is pushed into the aorta and towards the whole body, and that is responsible for systolic blood pressure. Then, but why do we get diastolic blood pressure? So, whenever the heart contracts and the blood flows into the aorta or any elastic arteries, the arteries enlarge. As you can see in this picture, they accommodate and they enlarge in size. And the moment heart relaxes, that is goes in diastole, the arteries come back to their normal position and maintains the continuity of that pressure, but the pressure is lower. That is why it occurs during diastole. That's why it is called as diastolic blood pressure. So now the point to be noted from this slide is, suppose someone's arteries become rigid due to atherosclerosis, then their diastolic blood pressure will become lower and their systolic pressure will become higher, because the elastic effect will be gone and the Windkessel effect won't occur. So that is why in cases of isolated systolic hypertension, we suspect that there is atherosclerosis in that patient. And isolated systolic hypertension also commonly seen in elderly people. So yes, afterwards I would like to start mention the criteria for hypertension. So the point to be noted that this is JNC8, that is Joint National Committee 8 criteria, and there is American Heart Association criteria also. So in our country, Joint National Committee criteria is accepted more. So first is normal blood pressure is considered as 180 systolic and 80 diastolic, and high blood pressure is more than 140 and 90, and then we say stage 1 and stage 2 based on if it's 141 to 159 in systolic and 160 or higher for stage 2, and similarly 90 to 99 for diastolic and more than 100 for stage 2. But what is important in this slide is the people who have their blood pressure in the range of 120 to 139 and diastolic 80 to 89 comes under pre-hypertension. So these are the people which are today's target for prevention of lifestyle diseases, and they can start adapting their lifestyle changes from young age only, so that they don't develop hypertension in later stage of life. So this pre-hypertension is very important. Then coming to hypertension classification. So basically there are two types of hypertension. One which we usually see in today's society, that is essential hypertension, that is hypertension without a cause. And then there is secondary hypertension, that is hypertension with cause. So when I mentioned primary hypertension, there are a few hypotheses being given behind the pathogenesis of primary hypertension. What actually happens that evolutionarily our kidneys are made to excrete potassium more and conserve sodium. But today our diet is like junk foods, and any high salt content diet is rich in sodium. So kidneys gets confused that our kidneys gets confused in how to excrete this extra sodium, which is our diet is rich in. So it can only excrete that sodium at elevated pressures. So kidney will increase the blood pressure so that it can excrete this extra sodium in the body. So that is why in primary hypertension, the first advice always is cut down sodium in the diet and increase potassium-rich foods. And also, if the patient has a family history and there are genetic factors working, there is stress, and there are increasing age are also risk factors for primary hypertension. So then going over to secondary hypertension, this is the hypertension which is this is the hypertension which is there is a cause for this hypertension. So CNS causes, like any cause of CNS where there is increased intracranial pressure. So the increased intracranial pressure, Cushing reflex will start, which consists of bradycardia, Biot's bleeding, and increased elevated blood pressure. Even CNS tumors can present in secondary hypertension. Then even psychogenic causes of CNS can cause secondary hypertension. In case of CVS, there is patent ductus arteriosus, and there is PDA and coarctation of aorta, vasculitis, polyarteritis nodosa. Renal causes. Yes, renal causes are very important for secondary hypertension or any renal problem, even diabetic nephropathy, nephritic syndrome, glomerulonephritis, Goodpasture syndrome, any kind of vasculitis, any kind of renal problem, polycystic kidney disease can manifest as hypertension, uncontrolled secondary hypertension. Then endocrine causes, your thyroid problems, hypothyroidism, hyperthyroidism, parathyroid related calcium problems, even Cushing syndrome, steroid induced, can be iatrogenic, even can be because of a tumor in adrenal gland, pheochromocytoma, and all these things. Then OBG causes are very important. Any pregnancy induced hypertension, preeclampsia, eclampsia. And in case of medications and toxins, medicines like steroids, alcohol withdrawal can cause hypertension. So we have discussed secondary hypertension already in a different video. So yes, let's focus our target on primary hypertension as of now. So yes, there are some few extra points, some special points at primary hypertension. The first is white coat hypertension. So this is a special type of hypertension which only occurs in hospitals. So the moment the patient sees doctor and the intervention, it will appear to be higher, but actually at home will be lower. So it is usually because of anxiety, and the patient be anticipating that the blood pressure will come higher. So patient should always be made comfortable. Just should have been sitting for the last 2 minutes. Patient should be calm to avoid this mistake of white coat hypertension. Then there is something called as paradoxical hypertension. That is, after we start prescribing patients antihypertensives, their BP even rises more. So these type of hypertension occurs in autonomic neuropathy, or in case of pheochromocytoma, it is possible. And even in rare instances, if a diabetic is taking beta blockers, so their hypoglycemic symptoms will be masked, and then they can present as paradoxical hypertension, even though there will be an antihypertensive. So then is masked hypertension. Again, masked hypertension is a very special entity which in masked hypertension, the patient, whenever will come to hospital, he'll have normal BP, and whenever the patient at home or outside will have elevated BP. This type of hypertension is very hard to diagnose and detect. And we'll come to clinical features of hypertension. So most of the times hypertension is asymptomatic problem. So patient won't have any symptoms at all. It will be detected on a routine basis. And rarely the patient can present transient headaches and polyuria. And there are few obstetric specific symptoms. If a patient is pregnant, then we always take history of these things. Is there any oliguria, that is decreased urine output? Is there any blurring of vision? There is any headache, pain abdomen, epigastric pain? And these might give us clue that patient is going for impending eclampsia or very high blood pressures. And at last, the clinical, I won't say it is a clinical feature, but it is a sign of investigation that sometimes on ECG, whenever there are non-specific ECG changes and patient otherwise is asymptomatic, the most commonly the cause is hypertension. Then yes, whenever we start any patient on antihypertensive drugs, before starting the patient on antihypertensive drugs, we need to be certain, and we need to do few investigations. And each investigation has its own purpose. So we need to do urine routine. Simple reason behind that, doing urine routine. A urine routine gives us a lot of idea about what is going on in patient's kidney. So we know that mainly there are many causes of secondary hypertension, but the most common causes are renal related causes. So by doing simple routine and even routine microscopy, we can pick up a secondary hypertension due to renal causes from this investigation. Then blood sugar monitoring and through HbA1c, fasting, and postprandial blood sugars are very important to detect associated comorbidity, because there is an entity called as metabolic syndrome. So whenever the patient has metabolic syndrome, he's at risk of lot of problems like hypertension, a lot of risk for any cardiovascular diseases, strokes, peripheral gangrene, infections. So we need to see that other risk factors are also controlled along with hypertension. So we need to rule out the patient does not have elevated sugars, patient does not have elevated lipids. That's why we also do fasting lipid profile. And a 12-lead ECG is important to see the current condition of the heart, that is the heart already in failure or in strain or some kind of early problem that can be treated at early stage. And then serum electrolytes is important, because of the simple reason that after my renal causes, my second most common cause of hypertension is adrenal causes. So adrenal causes like my Cushing syndrome and Addison's disease can be ruled out using serum electrolytes. So moving on to complications. So as hypertension is asymptomatic, ultimately we are treating it to avoid complications. So the main reason why these complications are occurring, hypertension causes vessel wall stress. So basically, normally in our blood vessels, whenever there is normal pressure, there is streamlined flow. But whenever the blood pressure exceeds the normal limits or becomes very high, it becomes turbulent flow and start injuring the vessels. So wherever the vessel injury will occur, all these macro and microvascular complications will start occurring. So related to brain, there is a possibility of transient ischemic attacks, cerebrovascular accidents. Cerebrovascular accident includes hypertensive hemorrhages, intracranial bleeds, even subarachnoid hemorrhages. If small vessels rupture due to high blood pressure, they can cause bleeding in the brain. And there is hypertensive encephalopathy. That can also be a complication of hypertension. Then in eyes, hypertension causes retinopathy. So in eye, it is graded using Keith-Wagner grading. And just for knowledge purposes, the common signs associated with hypertensive retinopathy seen in retina are AV nicking of vessels. There is copper wire appearance. There is flame-shaped hemorrhages. There is a Salu sign, gun sign, and bonnet sign. Just for knowledge purposes. Then in cardiovascular complications, there is a coronary artery disease and left ventricular failure. So the left side of the heart is working against the high blood pressure, and that's why it will get decompensated and will lead to left ventricular failure. And coronary artery disease occurs for the simple reason that again it will cause the high blood pressure will cause vessel wall stress and can cause and along with associated elevated blood sugar levels and lipid levels will cause narrowing and ultimately blockage, causing ischemic heart disease, or we call it coronary artery disease. Then coming to blood vessels again. So aneurysm is dilatation of blood vessel wall. So again, it's due to the repeated trauma due to the hypertension causing dilatation of blood vessel wall. And aortic dissection is the splitting of the vessel wall, basically making it double barrel. So there will be two lumens existing, and it is a very dangerous condition and should be taken care. Should be taken care immediately if detected. Then coming to renal complication, again, kidney is one place where there are very small vessels and capillaries and arterioles. So at that place also, it can cause renal failure, uncontrolled hypertension. Then at the end, coming to treatment guidelines, which are very important. So each and every lifestyle modification is very important. So first is obesity management. So it is very important to control obesity for one point that metabolic syndrome has one component of abdominal girth, and also there are two types of obesities. One is central obesity and one is overly distributed obesity. So when I talk about overly distributed obesity, so a person has fat deposition behind his neck, over his face, thighs, abdomen, arms. So the fat is evenly distributed. So there is comparatively less insulin resistance as I compare it to if whole of the fat is deposited over the abdomen, because it is only the adipose cells undergo only hypertrophy, not hyperplasia. So the more hypertrophy they go, the more the insulin resistance. Then the second point is dietary modification. There is something very important and specific for hypertension, that is DASH diet. That is dietary approach to stop hypertension. So these are the diets which are rich in potassium and have a low sodium content, and there's and all hypertensive should consume very less sodium in their diet. And the reason we have already discussed that to excrete extra sodium, the kidney will compensatory increase the blood pressure. So to remove that point, we need to consume less sodium. Then next point is exercise. So brisk walking is very important. We can advise anyone to go for 30-minute brisk walking at least 3 to 4 times a week. And then cutting down alcohol and smoking, because smoking causes increases carbon monoxide levels in the blood and also causes repeated catecholamine secretion, which even helps in increasing BP. So we don't want that in hypertensives. Then stress control and meditation, even without disease, they are very beneficial for everyone. So yes, they should be done regularly, and also they'll help to control psychogenic stress. So they will control the BP in that manner. And ultimately coming to medications, which we will eventually prescribe to the patient, but then lifestyle modification is also very important. So coming to medication, there are multiple medications available. I'll just cite out few names. So in diuretics, we have thiazide diuretics, example chlorothiazide. We have loop diuretics, furosemide. We have potassium-sparing diuretics, aldosterone receptor blockers, beta blockers, alpha blockers, alpha plus beta blockers. Then AC inhibitors and angiotensin receptor blockers. AC inhibitors are very important. We have famous AC inhibitors: captopril, enalapril, fosinopril, perindopril, all the prils. And then coming to angiotensin receptor blockers, we have telmisartan, losartan, candesartan, irbesartan. And calcium channel blockers, the calcium channel blockers, we have amlodipine, nifedipine, all those drugs. Alpha blockers, we have prazosin. Central sympathodietics, we have methyl dopa, alpha plus beta blocker, labetalol, and renin inhibitors, aliskiren, vasodilators, minoxidil, all those drugs. But we will just know more of some. We'll read discuss more about AC inhibitors, CCB, and diuretics a little more, because they are the first line drugs. So when talking about AC inhibitors and ARBs, so how they work is our liver releases this substance called as angiotensinogen. Angiotensinogen gets converted to angiotensin 1, and that angiotensin 1 gets converted to angiotensin 2 with the help of this enzyme ACE, that is angiotensin converting enzyme. So this angiotensin 2 causes vasoconstriction of all the vessels, and that is ultimately causing increased blood pressure. So we give drugs, AC inhibitors, which will inhibit the conversion of angiotensin 1 to angiotensin 2. And that is why that's how these drugs are working. And another approach is to block the receptor where angiotensin 2 is acting. And those are the drugs, angiotensin receptor blockers. And calcium channel blockers are acting on the calcium channels of smooth muscles of vessel walls, and again causing vasodilatation and leading to decreased blood pressures. And diuretics causes water excretion, so yes, they decrease BP through that method. So the dictum. So if a patient is young and if patient is old, young patient is defined as less than 55 years of age, old patient is defined as more than 55 years of age. So any patient who is young, we start the first drug is A. A here refers to AC inhibitors or ARBs. So A is for AC inhibitors and ARBs. And C is for calcium channel blockers and D is for diuretics. So A is AC inhibitors or ARBs, C is calcium channel blockers or diuretics. So if the patient is young, the first drug is to be given as ACE inhibitors or ARBs. If the patient is old, the first drug is to be given as calcium channel blockers or diuretics. And then after maybe 1 week, we can see the improvement. If there is no improvement or if the results are inadequate and we are not able to reach the target of below 140/90, then we add on the drug. Either we make it AC inhibitor plus calcium channel blocker, or we make it AC inhibitors or diuretics. Basically, what we mean to say is, after the first line, when we go to second line, then having AC inhibitor in the regimen is a must. And when the patient BP is not controlled over even AC inhibitors and ARBs, AC inhibitors with the calcium channel or diuretic, we add all three. And it's very interesting to know the point here that if the patient's BP does not get controlled even on ARBs, calcium channel blockers and diuretic, we label it as resistant hypertension and we use higher drugs for those patients. That is beyond the scope of our discussion. Then what are the common medications available under AC inhibitors, calcium channel blockers and diuretics? So the commonly used AC inhibitors are enalapril and ramipril, and ARB is telmisartan. So telmisartan comes in the dose of 20 mg, while calcium channel blocker, the commonly used one is amlodipine 5 mg. So when we're talking about diuretics, the most effective diuretic is hydrochlorothiazide 12.5 mg, which is a thiazide diuretic. And the point to be noted is the most potent of all the three, A or C or D, the most potent is diuretics. Then moving on to some important terminologies, I will just mention that what is hypertensive urgency, emergency and malignant hypertension. Without discussing these 3-4 terminologies, our discussion on hypertension is incomplete. So what is basically hypertensive urgency? It's blood pressure more than 180 by 120, that is systolic 180 and diastolic 120, there should not be any systemic symptoms or any complications. So when there are no complications associated with hypertension, very high hypertension, that is 180, 120, we call it urgency. But when it involves any system, we call it emergency. So emergency can be associated with cerebrovascular accident, intracranial bleeds, acute pulmonary edema, sudden heart failure, renal failure, and all these points. When I talk about malignant hypertension, it is again a form of hypertensive emergency, but it has quite progressed, and patient usually presents with retinopathy, renal failure, and cerebral edema. And resistant hypertension we have already discussed. That is the hypertension which does not come under control even with A plus C plus D. So this regimen here, whenever it even after A plus C plus D, it doesn't come under control, I call it resistant hypertension. And in the end, I will just add these points that if a patient has these conditions, then there are certain antihypertensives which are preferred over the other ones. So when a person has benign prostatic hyperplasia, that is a prostate problem occurring in elderly males, and they have accompanying hypertension, then for BPH, the drug which might work as alpha blocker. So to avoid giving two drugs, we can use an alpha blocker which can solve both the problems together. Then if any diabetics with hypertension, AC inhibitors and ARBs are beneficial, because a few studies have shown that over the time for diabetes patients, the mesangial proliferation in kidney is reduced by these drugs like AC inhibitors and ARBs. Even for congestive heart failure, these drugs are useful because they slows down the remodeling of heart. And then in pregnancy, if there is hypertension, then labetalol is the drug of choice, and there's no other drug we use, and it's not even advised to use any other drug. Even AC inhibitors and ARBs are contraindicated in pregnancies. So thank you. Any question? We'll conclude today's session. I hope you liked it and understood some things about hypertension. Thank you.